Ladies and gentlemen, we now have our presenters in conference. Participation in this presentation is by express written invitation of the AHA only. Unauthorized participants and or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call or log off the webinar if the AHA did not expressly invite your participation. Please note you may submit your questions and comments anytime using the chat pod located to the right-hand side of your webinar platform. It is now my pleasure to turn the conference over to Rebecca Jicky.
Thank you, operator. And on behalf of the American Hospital Association, welcome to today's webinar featured by the AHA Physician Alliance as well as AHA's Behavioral Health Services Division. The title of today's webinar is Stigma Kills, Addressing Opioid Use Disorder by Changing Culture. And it is my honor today to be able to introduce Richard Botner, who is from the Division of Hospital Medicine at the Dell Seton Medical Center. He's also affiliate faculty of internal medicine at the Dell Medical School at the University of Texas at Austin. So I am going to turn it right over to Rich, but first encourage everyone to think about the questions, because we are going to try to leave 10 to 15 minutes towards the end of the webinar to allow you to really roll up your sleeves and dig in and ask and have a dialogue with Rich. So we want this to be robust, and just keep that, you can submit questions at any time if you like. And Rich, I'm going to turn the platform over to you.
Great. Thank you so much, Rebecca. And hi, everybody. Welcome to the program today. I'm so excited to be here and to present this information to you. I think there's so much that we can talk about when it comes to stigma. And so I'm really grateful that you've chosen to spend some time with us today. Here. Oops. There we go. I have no commercial disclosures or anything like that, but I will say that I'm from New Jersey and I'm very passionate about this topic, but I'm going to try to not use my hands too much and to talk as slowly as I can and make sure that we have time for questions at the end of this. And I kind of want to start out by talking a little bit about why I'm the one to talk to you about stigma today. There are many experts about stigma in substance use disorders in the country, but I think part of why I am personally so invested and interested and excited to talk with you about this today is that I come at this from two different angles. One is as someone who is extremely interested in best practices for the delivery of care within hospitals. I've always been just very obsessed with hospitals and how hospitals function and the processes that exist within hospitals, and so I have a vested interest as somebody who practices clinically in the hospital to make sure that we're being as efficient and effective as we can with our care delivery in the walls of hospitals. But I also am very passionate about this because I often talk about how I'm in this sort of recovery of my own, in the sense that I, before 3 years ago, was one of those individuals who stigmatized patients with substance use disorders. And it goes back to, over 20 years ago when I first started working in healthcare was as an emergency medical technician. And being an EMT for a 911 primary agency that was called to see patients in need, many of those patients who had substance use disorders, and the culture of the environment that I was working in at the time or volunteering in at the time was one that left me with certain beliefs and opinions about how these patients ended up in the position that they were in. And I can tell you that these were not positive beliefs. And I took all of that stigma, all of those ideas, and I brought them with me to my clinical training, many years later in PA school. And you would think that those notions would have been sort of pared down throughout my clinical training, but they were actually reinforced in my clinical training through experiences that I had in multiple different academic centers, in multiple different interactions with preceptors and supervisors and teachers. And then when I graduated and went on to, practice clinically, I took then, my previous experience and notions as an EMT plus all the kind of baggage that I was building as a student, and I brought that with me to my clinical work. And it wasn't until about 3 years ago where, as a quality improvement project to increase access to opioid use disorder treatment for patients within the walls of the hospital, specifically through a readmissions lens. And that was really a very targeted intervention with a very targeted sort of problem statement. Was how can we reduce readmissions for patients with opioid use disorder by offering buprenorphine therapy, buprenorphine being one of the 3 FDA-approved medications for OUD. And at the time, that was the whole goal of the project, was let's take this evidence-based, cost-effective, safe medication that's on our formulary, and let's introduce it to the hospital and increase, its utilization. And what I realized early on, and continue to realize every day that we do this work, is that the impact we've made on patients in the last 3 years doing this kind of work and offering this kind of program. We are the only hospital in the state of Texas that does this kind of work, and one of less than 100 out of the 6,000 hospitals in this country that actually treats the underlying substance use disorder as a routine part of hospitalization. And what I've realized is that offering the medication is a very small piece to the puzzle. It's what the medication represents. It represents a shift in culture, a shift in mindset to understand that addiction and substance use disorder, and in this case opioid use disorder, is just as important to address in the hospital as the other chronic medical diseases that we treat. So if a patient comes in with endocarditis or cellulitis, we're really good at clinically treating those things, but we don't ever really treat the underlying problem. And the reason that we don't treat that underlying problem is the stigma. And so I'm in sort of this recovery of my own and really trying to reflect on the last 3 years of the incredible transformational work that we've been doing to really meet patients where we're at. And so that's what we're gonna talk about today. So I've got 3 main objectives for us. We're going to talk a little bit about kind of what stigma is and how does it exist in different forms. We'll talk about the impact of stigma on care delivery, and then I'll talk a little bit about our experience at Dell and how we've really started to shift the needle of how we address substance use disorders in the hospital. And I'll preface it by saying we do not have an addiction medicine consult service. So we are a group of interprofessional and multidisciplinary stakeholders who work in the hospital, who are passionate about this, who have volunteered to really shift this to become our standard of care. And so the picture you're seeing here on the screen is the medical school to kind of orient you right across the street. So if you were standing at that funky statue that we call the shell, and your back was to it, and you were facing kind of this way, you'd be facing our hospital, which is a 220-bed academic medical center in the heart of Austin. So I've talked a little bit so far about why this work is important to me, and I've talked a little bit about how we've been on this journey as an institution for the last 3 years. And I would be, I don't want you to think that this was an incredibly easy process early on. We were sort of innovators in the regard that we didn't have a lot of examples of other institutions that were trying to do this at the time. So we were sort of learning as we went along. And in hindsight, I would say there are 3 main barriers to why we don't address substance use disorders in the hospital. One of those is education. And that's not, specific to physicians. That's specific to all healthcare professions. Historically, medical schools, PA programs, nursing programs, pharmacy schools really haven't taught about the role of addiction, not just in our society, but specifically within the role of the hospital. And so it makes sense that many of us really don't know how to appropriately address addiction in the hospital or in the community because we were never really taught how to do it. That's changing, and so I think the landscape will look very different 5 years from now or 10 years from now as current students, get that important education and we really push for curriculum reform. But in the meantime, there's this large group of us who really need some more education and an understanding of what the evidence says around hospital-based treatment. And we'll talk about some of that today. There's a second barrier, which is sort of the systems-based practice. So when we talk about opioid use disorder, there's certainly the X-waiver barrier, right? This idea that you have to go through an 8-hour training to prescribe buprenorphine as a physician, or a 24-hour training as a PA or an advanced practice nurse. I will tell you that you do not need the X-waiver to start buprenorphine in the hospital. You do need it to prescribe it at discharge, but anybody in the hospital who has ordering privileges can order buprenorphine as part of acute hospitalization. Of course, there's other issues at the systems level, like reimbursement and so forth. And the third one, which is the one that we're really going to focus on today, is the stigma, right? There's such a pervasive stigma within healthcare, and certainly within many hospitals, around how we think about patients with substance use disorder and the type of care that we're able to provide those patients during hospitalization. And I really like this next icon because I think this really represents how a lot of us feel, right? We have these three big groups of barriers, and it's kind of overwhelming, and at the end of it we kind of go, I don't know what to do. And so I think today we're going to give some tools and some deeper understanding around stigma, and then of course I'm happy to talk about the systems piece and the education piece as well. So let's kind of start by getting a definition, by grounding ourselves in a few important definitions of sort of what is stigma. If we're going to have a conversation for the next 40 minutes about stigma, it's probably important that we all have a shared understanding of what that means. And the origin of stigma comes from this Greek word stigma. And back in ancient Greek times, so a long time ago, a stigma was a mark. It was a brand that was burned onto the skin of slaves in order to mark them and to mark their low place in society. And so right off the bat, you can imagine that we are talking about physically branding a human with a certain mark. And that is the context by which stigma, continues today, right? Perhaps not with physical burning, but certainly with emotional burning and scarring. And then we have some more kind of formal, modern definitions. The original modern definition of stigma comes from Goffman. It's from the 1960s. And he actually says here, an attribute that links a person to an undesirable stereotype, leading other people to reduce the bearer from a whole and usual person to a tainted, discounted one. And I think it's important to recognize that stigma exists among numerous different patient populations, and it exists outside of healthcare in many different ways as well. So as we're talking about this, really focus in and look at this through a lens of substance use disorder, through a lens of addiction, right? And think about how we may treat a whole or usual person who doesn't have an addiction compared to the person with a substance use disorder who we often view as tainted or discounted. And when I say we, I'm talking the healthcare system at large. And then there's this another definition that I think really kind of brings these two previous ones together, which is describing stigma as a social construct where we are kind of, there's a distinguishing mark of social disgrace that's attached to others in order to identify and devalue them, right? So this is through a lens of that we are sort of specifically identifying individuals, so in this case individuals with substance use disorders, and then creating a system of care where they are devalued. And so stigma and the process of stigmatization consists of these two really fundamental and important elements, right? That we have to have that differentiating mark. We have to have that thing that makes somebody different. In this case, it's their substance use disorder. And then we have to have some sort of devaluation of that person, which I think we've all seen in one form or another in our work. So when we talk about stigma, though, there's all these other words that kind of percolate, and I think we need to sort of have a shared understanding of how these other things play into it. And those words are stereotype, prejudice, and discrimination. And the idea of stereotypes are that they are inaccurate beliefs of how we feel about a particular group of individuals, right? So we may, as an example, look at a person with a substance use disorder, and we may believe that that individual is dangerous, right? That's a stereotype, that people with substance use disorders may be dangerous. And if you read the scholarly work around this, there's a lot of academics who kind of make the argument that there isn't a whole lot we can do about stereotypes outside of shaping them when individuals are young. That in any society, across history, across anywhere on the planet, stereotypes exist, and there isn't a whole lot we can do about having general beliefs. The challenge is having a belief is one thing. Having a feeling that develops as a result of that belief is a whole separate conversation, right? So the stereotype is the belief that, again, as an example, somebody with a substance use disorder might be dangerous. The prejudice is having a feeling where you're now afraid of that individual, or we feel a sense of hatred towards that individual based on that stereotype, right? So that prejudice is of course, a major issue. And really at the crux of it, the end problem here is the discrimination, right? So stereotypes lead to prejudice, and prejudice leads to discrimination. And discrimination is the act, whether it's as an individual or as a system, where people do not have access to the things that they need. They don't have access to employment. They don't have access to safe housing. They don't have the ability to maybe get their children back from CPS. And in the context of this conversation, they don't have access to health care, right? And so when we talk about stigma, it's sort of an umbrella term that encompasses these three other terms below. And again, the main issue here that we're trying to solve, that we need to solve, is the discriminatory practice that is rooted in that stigma. And so just to drive this home a little bit further, there's three main kinds of stigma, and I think this is an important part of the conversation. So one is social stigma, and I think when we talk about stigma, I think that's what many of us think about. The social stigma sort of exists at the individual level. It's how we as individual humans or individual healthcare practitioners or individual administrators view another individual. Equally important to that, perhaps more important in this conversation, is structural stigma. And the important part about structural stigma is that it can be intentional, or as I've seen in many hospital systems, it can be entirely unintentional. But structural stigma is when we have policies, among other things, in place that end up resulting in disparate care for particular patient populations. And so just to give you an example through the lens of opioid use disorder, I've seen many hospitals who have fairly strict policies in place around restarting a patient's home methadone. So a patient's admitted to the hospital, they're engaged in outpatient methadone treatment, and there's very strict policies about how and when and at what dose that patient can have methadone restarted. That's a form of structural stigma, and of course there are many others associated with patients with substance use disorders having strict policies about when they can leave the floor, about who we send out with PICC lines for long-term antibiotics, and many others as well. And then the third is self-stigma, and this is one that we don't talk about enough, and we often have conversations sort of peripherally about people recognize that there's this overlap, this link between people who are experiencing homelessness and substance use disorders. And there's a lot of reasons that exists, but I believe that one of those main reasons is self-stigma. So self-stigma is kind of a process, and it starts with awareness. And awareness is sort of the early stage where the public develops a belief about something. So the public says that individuals with substance use disorders are weak, or they're not worthy of having the same kind of access to care as people without a substance use disorder. Agreement is when a person with a substance use disorder says, yeah, that might be right. People with substance use disorders might be weak, or maybe they are weak. Then there's application, where the person with a substance use disorder says, well, wait a minute. If people with a substance use disorder are weak, I have a substance use disorder, so I must be weak. And that results in harm, because then the person with a substance use disorder says, well, if I'm weak, then I must not be worthy or able of getting the kinds of things that people without my problem, without my substance use disorder or addiction can get. And ultimately, that results in what's called the why even try effect. It's this profound feeling of hopelessness and helplessness that individuals feel. And we often don't know how to contextualize that in a hospital, right? Or in healthcare in general. But this model that you're seeing on the screen is a really effective way of thinking about this, of when you're interacting with a patient and they have this deep sense of hopelessness, that it's a process to get there. That does not happen overnight. That happens over months and years of interactions with the healthcare system that don't help patients enter recovery or maintain recovery. And I want to be clear that we're together for an hour, and I'm going to try to impart some of this wisdom on you. But stigma is complicated, and so I'm not going to go into this the pictures that I'm going to put up here in too much depth, because it would take a while. But this is from the main health care agency in Canada. They did a study about the role of stigma and how it prevents access to care for substance use disorders. It's fairly recent. It was last year. And their framework for sort of dismantling stigma relied on these 4 buckets, right? So number 1 is describing stigma. What does stigma look and feel like? 2 is the impact of stigma. So how does stigma get in the way of us being able to provide care? 3 is trying to identify the source of stigma, right? What are the different points and tensions that exist and the different contributing factors? And then the last one is how do we fix this? What are promising approaches to tackling and dismantling stigma? And again, I won't go over all of these bullet points in the interest of time. I'll leave them on the screen for a couple of minutes just so we can kind of screen capture them. And if we have time at the end, I'll go back to it. But I think the point here is that stigma is complicated, and I commend you for taking an hour out of your day to even come to a session like this, because understanding stigma, having educational opportunities around stigma, and then having somewhat difficult discussions about how we reduce stigma is how we ultimately move the needle. I also think it's important to have a brief conversation about how patients might refer to themselves, right? And so this is often a question that I get when we're educating some of our trainees about, we say, well, please don't use this kind of language. And then somebody will say, well, but the patients use certain language themselves, so isn't it okay for me to use it? And the answer is no. So in this study, and there are several studies like this, there was an evaluation of over 250 patients at a substance use clinic in Massachusetts. And patients most commonly refer to themselves as an addict. And when we look at the literature and we make recommendations, as we'll talk about later in this presentation, about kind of appropriate language that we should be using, we as healthcare professionals should not be using the word addict. But patients may refer to themselves as addicts. The least common term that patients use to refer to themselves was junkie. And then patients had opinions about how they wished to be referred to. A person who uses drugs, a person with a heroin addiction, or a person with a heroin dependence, talking about opioid use disorder here. And they did not want to be referred to as abusers or as people who abuse drugs. And the theme with the preferred terms is that we're using patient-first, recovery-centered language. So when I was in clinical training, it was drilled into our head to use patient-first language. We were in trouble if we said the diabetic patient or the heart failure patient, right? These are individuals, these are humans, these are people with diabetes, with congestive heart failure, et cetera. And for some reason, when we talk about substance use disorder or addiction, that all of a sudden doesn't apply, and we don't use those same boundaries, those same rules, and we should. And so I think it's important to also talk about how does this all kind of manifest in clinical practice. So so far I've shared a little bit of kind of theory and some stuff from the literature, but how does this all kind of shake out within clinical practice? Well, we know it's been well validated that health professionals as a group, the big generalization here, have a negative attitude toward patients with substance use disorders, especially when we are comparing diagnoses, right? So on average, healthcare professionals would much rather treat a patient for high blood pressure or diabetes or heart failure than they would treat a patient for a substance use disorder. And we know that when there's stigmatizing language in the medical record, that patients don't get the same access to treatment of pain or to the same access of treatment for other medical conditions either. And then we also know that the stigma progresses as we go through our development as healthcare professionals. So in this one study, it focused on sort of the continuum of physician education, but there's a lot of really important kind of learning points here that I think apply to any health profession. And basically, they looked at medical documentation between medical students. They found that the stigmatizing language in medical record was worse among resident physicians, and then the stigmatizing language was even worse in attending physician documentation, right? And again, I strongly feel that this is not one individual's fault, right? This is as a healthcare system, through all of the kind of barriers that I described earlier, this is sort of where we're at right now, and it's up to us, it's up to all of you who have clearly expressed an interest in this because you're here today, to start creating change and to change knowledge and attitude and ultimately behavior. To give you some more examples of how this all kind of percolates into clinical practice, we know that for patients with opioid use disorder who are engaged in buprenorphine or methadone treatment, that they are often asked to stop certain treatment in order to be candidates for liver transplantation. And so we know that those medications are life-saving. There's an abundance of evidence around that, yet we are asking patients to discontinue life-saving medications in order to gain access to a life-saving intervention like a liver transplant. Patients are sometimes denied valve repair surgery in endocarditis. There are cardiothoracic surgeons who, for a variety of reasons, choose not to offer a valve replacement to a patient who has endocarditis from an infectious source, particularly from intravenous drug use. And that same cardiothoracic surgeon would likely be more willing to perform that surgery on somebody without a history of drug use. And what we certainly don't talk about enough in this country is how opioid use disorder and substance use disorder affects pregnant patients. It has a profound effect on pregnant patients, in particular through stigma. Pregnant patients often face this sort of double stigmatization because their experience with the healthcare community is that those individuals, those practitioners, will stigmatize the mom for her drug use, but then she'll be doubly stigmatized because she's using in the setting of being pregnant, and the perceived harm is not only to herself but also to her unborn child. And so, again, we do not talk enough about pregnancy and the stigma associated with substance use in pregnancy, and I think we certainly need to do that. And, of course, substance use disorders are treated as a moral failing by the majority of healthcare systems. We look at substance use disorder as within the individual's control, and often we get frustrated because we can't understand, well, why don't you just stop using, right? Why, you keep coming to the hospital with issues related to intravenous drug use, endocarditis, spinal abscess, cellulitis, the list goes on. Why don't you just stop, right? That's a theme that, I've seen in many institutions. And so we treat it as a moral failing when, in reality, substance use and opioid use disorder is driven by genetic and environmental factors that are numerous. And what I think is even more important to tease out here in addition to the fact that there are many biopsychosocial factors that contribute to addiction, just like hypertension and diabetes and other diagnoses, is that we often talk about the quote-unquote, frequent flyer who comes to the hospital, but the rate of recurrence of disease is actually higher for other medical diagnoses. And I often use the example of diabetes. You could have a patient come to the ER and get admitted for the third or fourth time in a 3-month period for profound hyperglycemia, and that patient is going to get insulin, they're going to get counseling, they're going to get a prescription for insulin at discharge, and in most cases they're going to sort of have their hand held both within the hospital and in the outpatient setting until they make it to that follow-up appointment where they can engage in outpatient treatment of their diabetes. And that happens no matter how many times the patient with diabetes gets admitted for hyperglycemia. And we do not have the same thought process or mentality or system of care established for substance use disorder or opioid use disorder for that matter, even though the psychosocial factors are very similar, the biochemical factors are very similar, and the rates of recurrence are very similar, if not actually a smidge better than some of these other diseases. This is the definition of addiction from the American Society of Addiction Medicine. I won't read it to you in the interest of time, but again, I think it's important to kind of understand that when we talk about addiction, we are talking about a multitude of different factors, and ultimately these are factors and disease processes that limit an individual's quality of life. And so just like we want to improve quality of life around any other chronic medical disease, we want to do the same thing for patients who have a substance use disorder or an addiction. When we talk about the public feels a certain way about patients with substance use disorders. They often, will see these individuals as reckless or unreliable or undeserving of care or threatening or hopeless or kind of blameworthy. And oftentimes patients are being seen as being linked to increased prevalence of HIV or hepatitis C or driving under the influence. And all of those things, like HIV and hepatitis and driving under the influence, all have their own stigma attached to it. And so patients with substance use disorders are being stigmatized just because of their substance use disorder, but then they get doubly stigmatized because they get associated with these other things that are also highly, highly stigmatized. And in a survey, of 1,000 adults across the country, different geographies, different age, different education, 75% felt that patients with opioid use disorder were themselves to blame and really didn't make that connection with other chronic medical diseases and the biopsychosocial influences. I think it's really important that we have at least a brief conversation when we talk about stigma about the role of drug policy in developing our societal stigma and institutional stigma and structural stigma in terms of legislative and regulatory implications. This is an important conversation. We could do a whole hour just on drug policy, but what I think is really important to talk about is the disparities that have existed in drug policy in the United States that has resulted in highly disparate criminalization and incarceration, and particularly in communities of color around drug arrest. And again, we could have a whole separate talk about it, but I think it's important here because the war on drugs that was initiated in the 1970s and continues in different but very similar or related forms today has largely influenced how we think about drug policy and therefore access to drug treatment. So back in the 1970s, the focus was on cocaine, and in particular in communities of color, the amount of cocaine or the weight of the cocaine was such that powder cocaine, which was mostly used by white individuals, was light enough by weight that the penalties for possessing powder cocaine were much less, and the weight compared to more sort of rock cocaine was much higher, but rock cocaine was less expensive and often found in communities of color. And so, as you can imagine, those laws, that structural stigma, the structure that we put in place in the 1970s, resulted in mass incarceration. And so the issue was cocaine back in the 70s and 80s, and now it's heroin, and a very, very similar type of problem that has now percolated as a result. And as an example of this, white patients are 35 times more likely to receive treatment for opioid use disorder compared to black patients. And I wish we had, infinite time today, and I would talk much more about this, but this is a very, very important topic to understand and appreciate as we work to dismantle stigma of substance and opioid use disorder. So how do hospitals kind of fit into all this, right? Hospitals are critical access points. And I don't want anybody to walk away from this presentation thinking that myself or my colleagues advocate for hospitals to be treatment centers, because that's not the deal. The deal is that we want hospitals and strongly believe that hospitals, just like hospitals play an important role in starting patients on treatment for other chronic medical diseases and addressing acute illness, so too we should do that for substance use disorder. So the hospital shouldn't be the treatment center. The hospital should be the critical access point, the critical transition point that helps patients enter or continue their journey to recovery. And so we have to do a better job of screening and managing and treating opioid use disorder and substance use disorders in the hospital, and providing harm reduction. And even though we're really talking about opioid use disorder today, this is really true of all substance use disorders. There's a principle in all of this work called "not in my backyard" or NIMBY. And the whole idea with NIMBY, which is not really translated to the hospital typically, but I'm going to make that link here, is that there's lots of individuals in the country who feel passionate about increasing access to care for substance use disorder. And NIMBY is often studied through the lens of methadone clinics or what are known as opioid treatment programs. And so you'll go to an area where there's a new methadone clinic being proposed, and you'll survey the people that live in that area, and they'll all, for the most part, say, I support access to treatment. But then when you ask them questions about the clinic being in their neighborhood, the responses are all of a sudden very different, and no, I don't support treatment. And I think that has a lot of application to the hospital, because I think as healthcare professionals and healthcare providers, we certainly don't mean to stigmatize these patients, right? Again, there's lots of reasons that we've ended up in this kind of situation and have these thought processes that we have, right? And so I've never met a single person who is knowingly trying to discriminate against a certain patient population. But the whole idea of NIMBY comes to play here, because there are many individuals who I've met who have said, but the hospital's not the right place. I support treatment, but not in my backyard, not in my hospital. And I would really encourage us to think about how that approach is clearly not the right approach, because that's been the approach for the last several decades, and we haven't really moved the needle in hospitals. And as we've seen at our institution, we certainly can move the needle if we invest just a little bit of time and energy into doing so. So what do we do at most hospitals today? Most hospitals, we treat withdrawal, right? And we don't really set patients up for long-term success or a long-term treatment plan. And this is a really good study. It's a little bit older, but essentially in this study, they took patients who were presenting to an emergency department, and they treated all of them for opioid withdrawal. These were all patients who were using heroin. And they followed them for 30 days. 80% of those patients were back to using heroin in less than 30 days, because the hospital system in this study didn't have an infrastructure for connecting those patients to care or for treating their opioid use disorder. So we know that by not addressing it, by not treating it, what we're really doing is sort of fueling that cycle, right? We have an opportunity to break that cycle, and we can do that as a hospital. And patients are often hospitalized for consequences of opioid use disorder. I think we often think of it as medical professionals as overdose, right? Patients only come to the hospital as overdose, and we look at it through this very narrow lens of the patient who comes to the ER, has an overdose, usually leaves within 24 hours unless they require, critical care, et cetera. But there's this whole other group of folks, right? There's folks who are admitted to the hospital for some other reason, and they start experiencing withdrawal and often leave against medical advice because of that. There's patients who use intravenous drugs who have a sexually transmitted infection. They present to the hospital for complications of that, complications of hepatitis C, endocarditis from intravenous drug use, epidural spinal abscess, skin and soft tissue infection, and cellulitis. So there's a much wider audience of individuals that we can really sort of cast a wide net and offer treatment and intervention for these patients when they're in the hospital. In hospitalization, as has been described numerous times in the literature, is a reachable moment. It's an opportunity where patients are outside of an environment that's potentially triggering and hopefully surrounded by a supportive and destigmatized staff that can really reach that patient in that moment of need and help start or continue their journey to recovery. We know that up to 30% of patients leave the hospital against medical advice who have a substance use disorder. And it's because we don't address withdrawal. Those patients have appropriate fear of mistreatment based on their interactions with the hospital system for many years. And they have cravings for opioids that are not appropriately being addressed by the healthcare system. And in sort of this landmark study from 2014, they started patients on buprenorphine during hospitalization. They were randomized, and they followed these patients. And they tried to link patients to outpatient care. 12% of patients who were provided an outpatient appointment but were not provided any sort of treatment in the hospital made that follow-up appointment. So 12%, not so great. But 72% of patients who were provided treatment alongside their reason for hospitalization, which again could have been endocarditis or cellulitis, et cetera, made it to that follow-up appointment. Readmissions, right? Readmissions is sort of the holy grail of practicing in a hospital setting. And would you believe that patients with substance use disorders are more likely to be readmitted within 30 days, even when we adjust for age, for sex, for depression, for insurance type, for housing, and for Charlson score, which is sort of our score of comorbidities. So these are like some pretty robust adjustments. Even when you adjust for all of those things, patients with substance use disorders are 1.7 times more likely to be readmitted to the hospital. Patients engaged in buprenorphine therapy, on the other hand, have a 53% reduction in hospital readmission at 30 days. I don't know any other intervention in the hospital that reduces readmission by that degree. And I also really think it's important to address the quadruple aim in all of this, in particular, what makes the quadruple aim, which is care team well-being. And so we've seen this in our own institution where we have provided tools on the tool belt of not just our clinicians, but our nurses and our pharmacists and our social workers to be able to actually provide effective treatment to patients that actually improves staff satisfaction because they feel like they have something to offer and they can actually help patients. So going back to our journey, and I'm keeping a close eye on the clock here, so I do want to make sure we leave time for Q&A. So going back to our journey for our institution, our problem was basically this. We're a 200-bed academic hospital. We have patients with opioid use disorder. We do not have a formal addiction medicine service. How can we contribute to a solution? And that solution for us was utilizing existing teams in the hospital, using an interprofessional and multidisciplinary approach. And so what you're seeing on the screen here is a group of physicians and nurses and social workers and pharmacists and chaplains that all came together. Nobody, was sort of paid to do this specific work outside of our chief of psychiatry, who was part of this work as well. But these were groups of individuals who volunteered to develop the system in our hospital. And if you're thinking, I don't have those people at my institution, I can't do this, I would strongly encourage you to rethink that, because I thought I would have 1, maybe 2 volunteers to do this with me. We have well over 15 now, and we're growing very quickly. People feel passionate about this, but because of the stigma, they often feel hesitant to be the one to say, I want to help change the system and improve the system. So our team is called the buprenorphine team. It's not an addiction service. It is a targeted intervention for a targeted patient population, which is a group that offers buprenorphine. And we work to screen patients for OUD, initiate buprenorphine therapy during hospitalization, link patients to care at discharge, and then educate the entire institution about OUD and OUT treatment. And in the interest of time, I'm actually not going to go over kind of the nuances here. I'll leave this on the screen just for the purpose of screen capture. But I'll sum it up by saying we've developed this group of individuals, this subject matter expert group that trains our trainees, trains our residents as well as our attendings about opioid use disorder, has some people with X waivers so that we can start the buprenorphine in the hospital. Even though you do not need an X waiver to start buprenorphine in the hospital, we will prescribe it at discharge. We've built those relationships in the community. We've done a large amount of education. And then again, we've done all of that without the addiction medicine consult service with the goal of planned obsolescence, with the goal of this being our standard of care where all practitioners understand and appreciate opioid use disorder and the role in hospital-based initiation. And so what we learned about treatment and stigma in all of this was that the initial part of all this, which is what I was addressing earlier, was that we were doing this as a quality improvement project to kind of offer this medication to individuals. But what we learned was that what we were actually doing in a more impactful way was reducing stigma. By having conversations about the medication, we were also having conversations about the system of care. We were also having conversations about discrimination, and we were also reducing stigma. So we did a lot of education, a lot of messaging, a lot of conversation facilitation, and really a lot of role modeling around what is the appropriate way to talk with a patient who has opioid use disorder and to document in the medical record. And the bottom line really is that addressing OUD in the hospital is now our standard of care, and it's what we do for every patient who can benefit. So probably the most important part of this whole presentation is what can you do today leaving this program? And we're going to go over these real quick, and then I'll wrap it up. So using person-first recovery-centered language, identifying and eliminating structural barriers in your institution, providing a sympathetic narrative, and then really the biggest thing I think is start focusing on solutions. How frustrating is it for all of us to constantly talk about the many, many problems that patients with substance use disorders have in accessing care? If we shift that conversation and instead talk about potential solutions that we can start today, that in and of itself starts to move the needle. Using appropriate language is critical. It's critical in the medical record. It's critical in conversations we have with our colleagues. It's critical in conversations we have with trainees. And it is critical in conversations we have with patients. So I won't read these to you. They'll be available in the slide deck. This is from the American Society of Addiction Medicine. But essentially, again, the take-home point is patient-first, recovery-centered language. Do not use the terms on the left of your screen, and do use the terms on the right of your screen. Absolutely encourage you to identify the structural barriers that exist in your institution. There are probably many that you haven't thought of before this presentation. Starting or continuing medications for opioid use disorder during hospitalization, looking at formulary restrictions, looking at better ways to coordinate care. I guarantee that no matter where your hospital is, there are individuals in your community who want to engage with these patients at discharge. So how can you develop those systems of care and that care coordination? And then get a better understanding of the regulatory environment. One of the biggest questions that I'm asked all the time, and I've already alluded to it earlier, is you do not need the X waiver to start buprenorphine as part of hospitalization. You only need it to prescribe at discharge. So in our 200-bed hospital, we have maybe 10 people with the waiver. That has not been a hindrance to care. We have many others who can start the medication even though they don't have the waiver. And then providing a sympathetic narrative. And in the interest of time, I won't give you the full narrative here, other than saying that what's on the screen right now is a picture that was drawn by the very first patient who we ever started buprenorphine for in our hospital 3 years ago. And it was like flipping a switch for this gentleman. He felt so much better and adhered to his care plan and was so appreciative and respectful of the hospital staff and did phenomenally well for the rest of his hospitalization. And at the end, he basically drew this picture. And it's a before and after of what it was like, not just being started on buprenorphine in the hospital, but even more so, it was interacting with our team, interacting with individuals and healthcare practitioners who treated him and addressed him like a human, like a patient, and not like a problem. So on the bottom of the screen, bottom left, is sort of him in despair prior to starting treatment. And if you go counterclockwise, he would talk about the mask being the mask of addiction and rolling the die because you never knew what you were going to be using, from the street, and it could be your last time using if it was, perhaps mixed with something that was had a higher mortality associated with it. He has a stopwatch on there because it was the time ticking away from his life because he had spent so much time using because he couldn't get access to care or people who cared about him. But then through the clouds, through the darkness of his addiction for many years was this light, light beaming through, and he described that light as not just buprenorphine, that was a small part of it, but about being at our hospital and having his endocarditis treated by a group of individuals who really cared about him as a person. And so if we can achieve this work, anybody can achieve this work, and I will leave you with just a couple of opportunities for further learning. One is the Reset Stigma modules. These are about an hour and a half long, hour to an hour and a half long, that were created by Dell Medical School with funding from the Association of American Medical Colleges, and they are specific to reducing stigma of OUD. It includes continuing medical education credit for physicians and nurses and social workers and pharmacists. It's entirely free, it's grant funded, and I would highly encourage you to check it out and share it with your colleagues. And then two is a close partner of ours, an organization called Shatterproof, which is working to really dismantle stigma of opioid use disorder throughout the United States. So I would recommend you check them out as well. They've got a lot of great resources. And with that, I left 7 minutes. I'm so sorry, but I'm also happy to stay on a little bit later if other folks are interested. That's my email address. I say this frequently, but people don't always take me up on it. Please reach out for any questions, comments, concerns. My passion, if you can't tell, is on improving systems of care for patients with substance use disorders in the hospital. And if there's anything that I can do to help you do that, I am beyond ecstatic to do so. So please don't hesitate to reach out. And thanks so much for being here.
Rich, thank you so very much. That was, and I'm going to use the words of two people who have commented on this in the chat box. Thank you. It was comprehensive, meaningful, and actionable. And so that just, I think, in a nutshell, summarizes what you were trying to share with us today and did so effectively. While people are queuing up for questions or thinking about what they might submit through the chat box to you, I have a question, and it goes back to the beautiful picture that the patient so graciously shared with you guys. Getting patient stories sometimes is something that many people feel awkward asking about or how to approach. Do you have some guidance about that? Because I do think that is, as you showed in the actionable steps, that's a key part of this. So guidance or suggestions on how to take that on.
Absolutely. We actually did a study recently of our team members trying to kind of better understand their experience, being part of this effort for the last 2.5, 3 years. And one of the sort of common themes was that for most of us who, again, don't have formal training in addiction medicine or substance use disorders, we're very nervous about how do we approach patients and have these kinds of conversations that we perceive to be very challenging and very uncomfortable. But what we actually found out was that for the vast majority of patients, and certainly not all, but for the vast majority, they have felt so stigmatized and they have felt so alone for so long that there actually really isn't a way to do it wrong. Now, of course, you can go in the room and you can say something very stigmatizing and completely, derail the conversation, right? But I think if you're genuine about wanting to know more about that patient's history for your own knowledge and so that you can better help that patient, and you go into it explicitly saying that. So I've had, early on, and actually even today still, we'll have a conversation with a patient where I open it and say, I don't personally understand what you're going through, but I'm here to help you, and I want to understand that. So I'm going to ask you some questions so that I can gain a better understanding about who you are as a person, and so that I can better help you as a patient here in the hospital. And I've had patients start crying just by saying that, because in their many years of being admitted to a hospital, no one's ever asked them a question like that. It's very clinical focused. Let's kind of get this patient in and out of the hospital as quickly as possible because we all know they're just going to be back again. And that's what happens at most places. So it's a great question. The other piece I would say is motivational interviewing is huge. And whatever opportunities folks have on doing, even if it's just a 30-minute or a 1-hour webinar like this about motivational interviewing, it can really help inform how you have some of these conversations.
I just want to let you know, because I know it's hard to speak and also read everything coming in at the same time, we've had 2 more people weigh in about fantastic presentation. In fact, one person says it's the best presentation they've ever attended on stigma and addiction and MAT. So you've set the bar quite high for future presentations. While I see if there's going to be other questions coming in, that was the soft question. I wonder, and you gave such excellent guidance that, don't be surprised when people are, if you approach them in the right way, as you described, that they're just almost, I shouldn't say overjoyed, but grateful that you're asking for their opinion and their feedback on this. But I'm wondering, you touched on going back to the sections on readmission. And the reality that so many times the reason for readmission may not be specifically related to opioid use disorder. It may be the physical implications of that. I feel like I'm going to put you on the spot here, but I'm wondering, I have a feeling behind this you are doing some additional calculations about how that may be reducing the overall total cost of care when you're able to use the hospital as, a point to start treatment, and then to connect with the right community resources outside that. So just insights on, even if you're just laying the foundation to try to put numbers to that, it would be helpful. Yeah,
so anecdotally, it definitely seems like this work contributes to reduced cost of care from our perspective. Studying this at a systems level is really challenging, and not just for us, but even when you look in the addiction medicine literature, it's really, really hard to do return on investment studies and cost effectiveness studies. They do exist though, and one of the ones that came to mind as you were speaking is actually out of Vermont, where they looked very closely at total cost of care across the Medicaid population in Vermont. And one of the challenges that I will tell you about developing these kinds of systems is for opioid use disorder, medications for opioid use disorder, so pharmacotherapy, of which there are 3 approved by the FDA, methadone, buprenorphine, and naltrexone, are very clearly evidence-based, cost-effective, safe ways to treat opioid use disorder. The challenge, in particular with buprenorphine, is that the medication cost itself tends to be higher than some payers are excited about. So buprenorphine is more expensive than methadone. Naltrexone is even more expensive, but there's access issues around that, so we'll just kind of take that off the table for a minute. And so when you look at the studies, people get scared because, and when I say people, I mean payers and policymakers, because they see the cost of the medication and they get nervous and they get worried. But you have to dig deeper and look, to your point, at total cost of care. So in Vermont, it was very clear that by developing systems of care in the hospital and in the outpatient setting, which were geared more towards buprenorphine, even though buprenorphine was more expensive as a medication, it increased the total cost of pharmaceuticals. It decreased the total cost of care. So I think we have to be really careful about what we're analyzing and how we're analyzing it. There is the National Institute of Health HEAL initiative right now, which is a huge, multi-year, very, very large amount of federal dollars and multi-center study around best practices for all of this. And so I think a year or two from now we'll have even better answers for how to address cost and return on investment.
That truly, thank you, because I know a lot of people on this call were wondering, how do I, yes, I can go out and get volunteers, but somehow there's going to be added costs. And so how do I approach that as I'm trying to make this happen in my own organization? I know we are just over the hour, but I wanted to ask if I can pose two quick questions that have come in on the queue. One person says, why do you think there's a misunderstanding around the legality regarding initiating buprenorphine in emergency situations and a lack of understanding around the 3-day rule?
It's an excellent question. So for the rest of the group, the emergency department has a loophole, if you will, to the regulations around buprenorphine. It's called the 3-day rule, and it allows emergency departments to dispense for kind of outpatient use, if you will, 3 days worth of buprenorphine medication for a patient. Now, you cannot dispense 3 days at once. The patient has to come back 3 days in a row and on each day get a single dose. And I would say the answer to your question about why there's misunderstanding about it is the same reason there's misunderstanding about needing an X waiver to order it on the inpatient side of the hospital, which is, I think, the intention of creating the X waiver through the Data 2000 legislation back in 2000 was to increase capacity in the primary care setting and for buprenorphine treatment. And we've been somewhat successful at that in the sense that we have more people doing the X waiver and we have more capacity overall, but the majority of people who get the waiver never actually prescribe. So there's lots of questions about kind of the current regulatory environment. But to directly answer your question, the X waiver in and of itself, the fact that you need 8 hours of training as a physician or 24 hours of training as a PA or advanced practice nurse, I personally feel creates this culture and this aura and this sense that OUD and buprenorphine is complicated, is complex, potentially dangerous or risky, because otherwise, why would you need to do 8 hours of training in order to prescribe this medicine? It's ironic that you don't need any training to prescribe the full agonist opioids like oxycodone, et cetera. But that answer, to be clear, is fairly controversial in the addiction medicine community and in the policymaking community. So there are some who feel very strongly about needing the X waiver for the educational barriers I described earlier, in the sense that people don't have the education to do this. And then there are others like myself who feel like it's a pretty significant barrier to care. But I think ultimately that's what contributes to a lot of this misunderstanding that exists.
Thank you. I'll tee up one last question. And yes, we will share the slides. So in the chat, everyone, we've given you the website where they should be available later this week. But somebody said, asked the question, are there specific resources on addressing stigma about medication per se? So not about the OUD or about other addictions, but around the medication.
Absolutely. I could talk about this for a very long time. So first and foremost, reach out to me. Happy to have an offline conversation. To the professional societies, and there's actually a number of different organizations that have put together some really nice materials. I believe AHA has some, Shatterproof that I mentioned earlier has some, the American Society of Addiction Medicine, American Academy of Addiction Psychiatrists, the American Medical Association. There are several organizations that have put together some really nice content. I will selfishly plug our modules, which again, free online modules if you go to resetstigma.org, grant funded, so free for the taking and sharing. We have a whole section in there specifically talking about stigma related to medications for OUD, including a section that actually teases out specific myths. There's 5 or 6 myths, and then there's information in those modules about how you can debunk those myths in case others have them. Again, I could talk about this much longer, but I probably shouldn't in the interest of time. But please contact me. I'm happy to continue the conversation. Oh, sorry, I can't hear you all of a sudden.
Oh, sorry. As working from home, there was somebody cutting down a tree nearby, and I put myself on mute. So I was just saying.
Joys of 2020.
Yeah, welcome to 2020. For those of you who we haven't been able to get to your questions or you think of them afterwards, please do reach out to Rich. He is more than willing. I think, as you have seen, he's offered multiple times to speak with each of you offline. Rich, since you put in a plug for the resetstigma.org, I will also add one in shamelessly. If you go to aha.org/behavioral health, all one word, across the carousel there, you'll see a number of resources, some related to opioid use disorder and some related to stigma. And so most of those we have worked very closely with the Physician Alliance staff, Elise Ayers-Pacachaga and her team to promote, but I will call out one last resource there on the stigma page that is past AHA board president Nancy Agee. It's a 3-minute video where she speaks clearly to her peers about the issues around words matter and echoing many of the same say this, not that examples that you shared with us here today. So if you are interested in, just maybe sharing that with someone on the C-suite team in your hospital, I think it can be very powerful and it's very short. So thank you so much for your willingness to share with us your expertise, your passion, your insights, your stories and examples. I know everybody that's participated in this webinar today, or those who may listen to it afterwards, are going to take away at least one, probably multiple steps that they can take to really make a difference in this field, in this area. So thank you so much.
Thanks so much for having me.
Operator, much as I hate to say it, that